Good afternoon, everyone. I'm very happy to present the results of another study in the same disease, indeed, those patients with mid-gut neuroendocrine tumors. Those tumors come from the small bowel and the right part of the colon. And this treatment used lutetium dotatate isotope, which improves progression-free survival in those patients. That will I show you. Sorry, because I changed something. Okay, it has not been changed. As Dr. Yao just alluded to, this group of NED patients is heterogeneous, and they are very special because those tumors may remain silent for months and poses very difficult diagnostic problems. Despite the fact that they are very rare in terms of incidence, and as you can see here from a work that was performed by James Yao, this incidence is really increasing in the recent decades. This is the red curve, which is now 5 for 100,000 people, while as you can see in the same time period, the incidence of all cancers did not increase so much. And this is probably because diagnosis is now more accurate. So sorry, coming back to what I just said before, this is a prevalent disease, as you can see, although the incidence is low, but increased a lot. The problem we have, especially for patients with mid-gut tumors, is that we have very few treatment options, despite the fact that we just heard one new option. But up to now, this patient, even at the metastatic stage, cannot be treated with chemotherapy, external beam radiotherapy. This does not work. Somatostatin analogues can be useful at the very beginning, but at some time point, we are without any treatment. And we know that this peptide receptor radiotherapy using lu-dotatate has given, in an investigational-driven study, very promising results. So, what is the principle of this? It's an agent that is injected by systemic route, and as you can see on the right part, you have both here a peptide, which is octreotide. Octreotide has receptors of somatostatin. Octreotide is a somatostatin analog. Somatostatin has receptors on the membrane cell surface and binds to the tumor cells. The radionuclide, which is 177 lu-dotatate, is bound to octreotide via a chelating agent, and this binds specifically, or rather specifically, to the neuroendocrine tumor cell because it targets somatostatin receptor. So, lutate is injected in the patient vein, it reaches the tumor cells, it binds to the somatostatin receptor on the cell membrane, is then internalized in the tumor cell, and delivers radiation within the cancer cell, leading to cellular damage and DNA destruction. In the study that we performed in almost 230 patients, half received lutate, the other half received octreotide LAR at the high dosage of 60 milligrams every 28 days. In the lutate arm, patients received also octreotide at the current dosage of 30 milligrams to control their symptoms. And you have here the major result of this study, which is a big difference, as you can see, in progression-free survival. It was 8.4 months in the octreotide arm, and it was not reached in the lu-dotatate arm. This corresponds to a hazard ratio of 0.209, or in other words, in a risk reduction of almost 80% in tumor progression. May we see tumor shrinkage with such a treatment, which is not observed with the other types of treatment? We knew from the phase 1-2 study that it was possible, and this is confirmed by the present study, although I must stress the fact that we just evaluate the patients who, of course, are currently available. The study is still in progress. But we can already say that 19% of the patients did experience an objective response according to RECIST criteria, while this was only 3% in the control arm with octreotide 60. Progressive disease was very rare, and tumor control was obtained in 95% of the patients in the lutatottate arm versus 76 in the control arm. Finally, exactly as you saw in the previous presentation, we performed an interim analysis of overall survival, but I think this is a little bit too early. And it is not yet significant because this value of 0.01 is below the threshold that was fixed before the study, but the study is ongoing. There is a trend, and we will see what will happen later on. Safety was not a big issue, and by the way, the safety data, which are also being now still, of course, completed in the study, were as we expected. Few patients, 7 of them experience blood toxicity with thrombopenia and neutropenia in some rare cases. 3 patients experience renal and urinary disorders, especially with 1 patient who got a renal failure and 1 patient had a portal hypertension, probably not related to the treatment. So I think we can conclude that in patients with progressive metastatic mid-gut NETs, lutatottate was superior to octreotide 60 in terms of progression-free survival and objective response rate. It might be that it can also be associated with increased overall survival, and this is to be confirmed. We can confirm also the fact that the safety profile is good with few severe side effects. And I really think that this new concept, which is now demonstrated, we needed this first prospective control study because the investigator-driven studies, which treated more than 1,000 patients, were, of course, not controlled. We have now, I think, reasonable evidence that this is a major advance in the population of patients with progressive mid-gut NETs. Thank you very much.
Thank you very much, Professor Ruszniewski. Ladies and gentlemen, just to make it clear, this is a patient population with a sort of identical tumor, but in a different location. That's what we heard before. So
among the patients that James presented, there were patients with mid-gut tumors also, and quite a good proportion, James.
Yes, a subgroup of the other population.
Okay, so how high was the percentage about?
I think in our study, I have the exact numbers, but I think it's about 25% were these mid-gut type. The rest were lung and other primary sites.
Still, this might very well be that this is causing a lot of a difference, right? I just want to avoid the question, what would you use now?
What I would say also is that among the different primary locations, mid-gut is the most frequent one.
Right. All right, questions, please. Don't ask us now.
It's really interesting. So, but what happens to the radionuclide? Does it just stay in the organism? And is the danger that it induces other DNA damage afterwards? Or?
I think there are several questions. We have conducted a sub-study in 20 patients, which will not be included in this analysis, to study the fate of the radionuclide. We know that it disappears progressively from the blood, of course, but the sub-study will give us some pharmacokinetic data about that. Can it induce damage in the long term? I think this is not at all impossible. This is radiation. I think that what we know from phase 1 and 2 is that this is probably possible but rare. especially the two organs that should be carefully watched are the bone marrow and the kidneys. I could not get into details, but to prevent kidney damage, amino acids are infused at the same time, so they compete with the radioactive compound so that there is no accumulation in the kidney and limit, and by the way, there is very limited kidney toxicity. Bone marrow, I showed you some acute data. Long-term follow-up will tell us. We know that myelodysplastic syndrome might occur in 3 to 4% of the patients in the long run.
Okay, there was another question, I think, right here.
Ed Sussman, Oncology Times. Again, Dr. Zielinski, we went from having no treatments to having what looks like possibly 2 treatments in the space of 30 minutes. So
that's how fast it goes.
How is this going to change clinical practice?
Well, I think we're here truly at the verge of changing, of practice changing, of having heard 2 practice changing presentations. The question which always comes up is what would you rather use? And the answer is I don't know, because that is something which would have to be tested in a head-to-head comparison. The question is again, how will we ever perform this? And I think that probably the United States have a better scenario for this with the help of the National Cancer Institute and all the support, rather than the European institutions, which are rather very much dependent on pharmaceutical support, because we don't have this kind of support of clinical studies in Europe, or at least in a very limited way. This is not the only scenario where we don't have head-to-head comparisons. We have a lot of scenarios where we don't have head-to-head comparisons. Just think about adjuvant treatment of gastric cancer. We don't know which one is the best, because we don't have, out of 3 options, in fact, we don't have a head-to-head comparison. So we have here options, and they are better than classical or golden standard, which was used until now. But we don't know which one is the better one concerning the choice out of the 2, right?
Maybe one additional comment to that is that we could not, of course, get into details, but the prognosis in these patients is quite different from those patients with usual cancers. Neuroendocrine tumors, well-differentiated neuroendocrine tumors patients, have a much better prognosis. So I think the issue is not to choose, because there will not be a second chance for the patient. Most of our patients receive all that we have. It's a question of order. And here it's true that it's difficult. We have some criteria. It will be a little bit too long to give details. But for instance, for the treatment I just presented, you should, of course, have strong uptake on somatostatin receptor scintigraphy, because if the patient belongs to the 20%, let's say, or 15% group who do not express strongly somatostatin receptors, glutathione will not work very well. Or, on the other hand, if the patient is not very tolerant to everolimus, has side effects, this is a long-term treatment. The patient has to take the drug every day. It's different, and the patient will not be treated by targeted therapies any longer. So we have possibilities to choose, and many parameters do influence our choice.
That is, I think, very important, because to put it into perspective, it is important to know that we have ameliorated treatment outcomes in general in malignant diseases by generating a cascade-like treatment option, where one treatment could follow the other, where we don't know the optimal treatment, in fact. Like, for instance, chemotherapy in metastatic breast cancer. Once you arrive at chemotherapy, you don't know which chemotherapy to choose first, and which at the second or third or fourth or fifth line. Similar in prostate cancer and advanced prostate cancer. It's very, very difficult to say which kind of treatment would be the best to use at which kind of which time point. However, we know simply from clinical practice, and when we analyze this, that the cascade-like use of one treatment after the other ameliorates treatment outcome. This might be a little different in neuroendocrine tumors, because they have such a good prognosis anyhow. But still, this might enrich very much our armamentarium also in treating these patients. And we simply don't know which kind of treatment will be the best at which time point, right?
Yeah, I completely agree with Dr. Ruszniewski as well. I think in this particular disease, I think we'll need both of these treatments, because most of these patients will survive one of these treatments, and eventually they will need the other treatment. So it may not be so important to know which one is better. I think a head-to-head study would be very unlikely coming from the US, even with the NCI framework.
Can I ask you one question which has not been asked yet? Is octreotide out?
Oh, no, I don't think so.
Okay.
Once again, be aware that those patients were included because they were progressing with octreotide at the conventional dosage. So this means that in the first part of their disease, they were sensitive to somatostatin analogues, and most of our patients, first of all, of course, for their symptoms, if they do have a carcinoid syndrome, but even for anti-tumor purpose, if they have not too aggressive disease, not too progressive disease, too fastly, I think somatostatin analogues, both octreotide and neuroendocrine, by the way, are really first-line, very well-tolerated treatment, and very easy ones. So no, I don't think it's out, but in those patients, by definition, it was out.
Sure. Please.
So my question is, do you think the expression of the octreotide receptor in tumor tissue can select the patients for suitable for this particular treatment?
It could, but we have an in vivo way to assess this, because what you say is, why not performing immunohistochemistry with somatostatin receptor antibodies to look at the expression of the receptors? This could be done, but what is more simple and more related to the uptake of the compound is to perform somatostatin receptor imaging, which could be with the indium, the so-called octreoscan, or a PET gallium-68 PET-CT, and check that the receptors are present.
Lynn Peterson with Trends in Medicine. Hi. So, since the comparison to prostate cancer was brought up, I would ask, with what's happened with RAD223, which has very good data, but is not really, it's usually scheduled behind abiraterone or the other drug.
Sorry, I didn't get very well your question. In pancreatic cancer?
In pancreatic cancer, we have abiraterone, we have enzalutamide, and we have RAD223. By the addition of a radiopharmaceutical with RAD223, the data is just as good, but it's used later because it's a radiopharmaceutical. And I'm wondering if we're not going to see the same thing here in NET.
No, I think it's a totally different disease. I think the comparison is very difficult to make. I would not comment on that.
Zsosha Chusteka, Medscape Oncology. Can I ask you about the progression-free survival that you saw? You say the median wasn't reached, but can you give some sort of idea of it's more than something? So
yes, it's a good point. From some calculations we made, and using, of course, the hazard ratio, it could be around 40 months. 40. 40.
Okay, and this compares with 11 months?
True.
Thank you.
Peter McIntyre, Cancer World. Is it possible to say anything about the relative costs of these two treatments?
Well, it's difficult because I think it's not yet approved, especially in some European countries and United States, of course, because this study is pivotal in this respect. And I think that on both sides of the Atlantic, it will be quite different. I don't have precise, I will not comment, I don't know the figures exactly, so I will not, I will try to give you the answer later on. More or less? I think it's not at all the same, because maybe what is not clear is these are very different ways of treating patients. With lutate, what happens is you perform, as I show, maybe I didn't have time to explain this in detail, you perform 4 injections to the patient, separated by 8-week intervals. And this is done. And then you follow the patient. With targeted therapy, and especially with the everolimus, it's a pill, and the patient takes a pill daily for a prolonged period of time that cannot be determined until it doesn't work anymore. So the calculations to compare the cost for this reason are not so easy, you see, because you have to use the pills for a long time. I would say that for a reasonable treatment duration, things will be comparable. I think it will not be very far, because the price of 4 courses of glutatate will probably not be very different from a reasonable duration of everolimus, probably. What do you think, James?
I agree. I don't think it's possible to answer that question because there is no price set for
Exactly.
glutatate. And to your earlier question, these PFS estimates are in very different patient population. You can see the control arm is very different as well. So I would, I think you need to let the data mature to know what the true medians are.
Okay, if there are no more questions, thank you. One more here. 2 more.
What about the environment and the radioactivity?
I think it's a safe drug. You have to take care of patients' urine and special devices to eliminate them.
Not only for the patient, I'm looking for all that it goes down in the water.
You are right. The people just wear a badge with a dosimeter to measure, but there is no major exposition provided some current precautions are taken. The patients are in current rooms. They do not need special rooms to be treated. So it's quite simple, I would say.
Ed Sussman with the Oncology Times. Very quick technical question. What was the pre-specified survival p-value that you were seeking for significance?
Well, the statistical bet was based on a PFS of 14 months in the octreotide group that was not reached, by the way, and a 50% increase with a p-value below 0.01, if I'm correct. I will check this.
I was asking regarding the overall survival.
So to reach the objective that I just mentioned, only 100 patients were sufficient. To reach the overall survival significance, the number of patients was increased to 230. So this answers your question.
But no, what would the p-value be for significance in that?
It was below 0.0018, if I'm correct, but I will check for you. I cannot perfectly. 0.0018.
3 zeros.
3 zeros.
Okay.
But let's check together. That's why, as you can see on the slide I showed, it could have been considered as significant, but it is not. Right. It is not.